Okay, this is a randomized clinical trial that compared two different regimens of vitamin D to evaluate its effect on children and adolescents with IBD to see if it could raise their vitamin D levels to an optimal level and maintain it throughout the whole entire year. This was a study done in 2014 in the state of Boston. So the authors began by introducing childhood inflammatory bowel disease and basically stating it's a chronic condition where the intestinal tract is destroyed and how IBD is associated with compromised bone health, which is where vitamin D plays a role. As we know, vitamin D has a very critical role in our bone health, and it also has a very critical role in our immunity since it has immunomodulatory effects where it regulates T cell proliferation, cytokine production, and regulatory T cells. The authors also reference a few studies where vitamin D may help with cases of IBD. So optimal vitamin D status is actually related to its effect on bone health. In human studies with adults, it has shown that bone health is optimal when vitamin D status exceeds 32 nanograms per milliliter, which is how the researchers use this as a benchmark for this study. Since IBD is an inflammatory disease, the concentration needed for vitamin D status to exert anti-inflammatory actions, they have not really been eluded yet. And there are some populations at risk for vitamin D deficiency, and IBD falls into that category. In a previous study, the authors have identified that there was a dose of vitamin D that was effective at treating low vitamin D status in children with IBD. However, when I looked into that study, it was a 6-week study. The authors here wanted a more longer effect and chose to do this randomized trial to compare the efficacy and the safety of two different supplementation interventions in maintaining the optimal vitamin D level of 32 nanograms per milliliter or higher, and also to examine the effect of both of the vitamin D interventions on the inflammatory biomarkers in children with IBD. Participants were all recruited from the Boston Children's Hospital, and the inclusion criteria included, of course, a diagnosis of IBD, the age group between 5 and 21, and their vitamin D status was greater than 20 about 8 weeks before the study began. The exclusion criteria included inability to take oral medications, pregnancy, organ failure like liver or kidney failure, or any kind of medications metabolized through the cytochrome P450 pathway. So for the interventions, the participants were randomized to receive one of two supplementation dosages. The researchers chose D2, cyanocobalamin, which is not as bioactive as the methylcobalamin, and they probably chose D2 because it's cheaper. So for the first arm, the participants had to take 400 IUs every day, and for the second arm, arm B, they were to take 1,000 IUs during the summer and fall months and 2,000 IUs during the winter and spring months. And all participants got a calcium supplement in addition. All participants were randomized from a concealed list. From the list was concealed even from the research pharmacists, and the participants were asked to return 4 times in a year, every 3 months. They were also checked for the anthropometrics. A physical exam was done, a questionnaire asking them about their sun exposure and their sunscreen, and also a nutritional assessment, since the objective was to test the vitamin D status. Blinding was done to the next treatment in order to avoid selection bias, but afterwards participants and investigators were not blinded. So for the outcome measures, the primary outcome, as I stated, was to check to see if vitamin D status reached 32 or above during all of the 4 follow-up visits. And the secondary outcomes measure the potential harm for vitamin D, because this study not only was evaluating the efficacy but also the safety. And additional secondary outcomes included inflammatory biomarkers, which is more related to our population, because in IBD it's an inflammatory condition. So they looked at things like ESR, CRP, and IL-6, interleukin-6. Exposure to UV radiation and other sources of vitamin D through food, through a 3-day food diary, all of this was taken into consideration, which I thought was great. Adverse events, there were not many adverse events, but it was reported at each visit, and the majority of the events were very minor. They were not serious at all. So for the results, as you can see here, there were a total of 498 children that were assessed for eligibility, and after meeting the inclusion criteria, 63 were randomized to Arm A and Arm B, and there were 32 in Arm A and 31 in Arm B, and a couple were lost to follow-up. About 2 of them withdrew in each arm, so there were 31 and 32 total. So they were pretty similar throughout. Here in Table 1, we see the patient characteristics, the demographics, anthropometrics, and any other clinical considerations are here. And as you can see here, the ages were pretty similar. The number of females were pretty similar, and the amount of Caucasians, non-Hispanic Caucasians, were pretty similar. The weights were pretty similar. They were pretty much similar throughout both arms, which added strength to this study. And here were the inflammatory markers. This is where the values differed a little bit more. So what the authors concluded here is that there really was no difference between both treatment arms in the primary outcome. Only 6 of the 63 participants, where is it? Only 6 of the 63 participants, here we go. There's only 6 of them in total, so 3 in Arm A and 3 in Arm B, achieved that optimal vitamin D status of greater than 32 nanograms per milliliter at all 4 visits. So that's not a lot. And the rate was only a little bit higher here when they analyzed it, restricting it to just 34 subjects at all 4 follow-up visits. So what the authors concluded is that there were some weaknesses in this study. There are some factors that may have affected these results, which they put in the table here. So this is the baseline of vitamin D status. This is the baseline weight, because weight also can affect vitamin D status, and the weekly exposure, and also how much they were supplementing with here. And there is with the 95% confidence interval, and only one of them, I think, crossed the 1 saw that across the one. So basically, one of the reasons why the authors what the authors concluded why this was not really effective was actually one of the limitations that they had noted, that probably using cyanocobalamin instead of methylcobalamin may have been a factor. I mean, this was the first study. This study was the first randomized controlled trial that evaluated the efficacy and safety of the two different vitamin D regimens in attaining vitamin D status above 32 or greater all year round. And they did look at the vitamin D status on the effect of vitamin D on inflammatory outcomes. But oral supplementation of 2,000 IUs a day was really not, it didn't show that it was successful in reaching that goal throughout the year. And at best, only 20% maintained that value. However, both regimens were well tolerated and safe. And in a secondary analysis, it showed that the higher vitamin D dose, they were actually able to maintain lower levels of the inflammatory markers, which was a good thing. However, the authors did note that this finding should really be interpreted with caution, because this study was not exactly powered to detect the differences in these inflammatory outcomes. So as far as the limitations of this study, vitamin D2 was selected, and as opposed to vitamin D3, probably because it's widely available. I mean, I think vitamin D3 is available too, but I'm assuming that vitamin D2 was a lot cheaper. And also, they didn't measure the free vitamin D, so that was also a limitation, because that may have helped them interpret the results with a different lens. Also, there wasn't a control group, so they were not able to compare the outcome with healthy children and adolescents.